Dr. Sankaranarayan. He's actually a radiotherapist and a clinical oncologist. He's currently senior officer, the visiting scientist at WHO-IARC, France, and the NHM expert for cancer programs, Tamil Nadu. He has provided technical support to more than 100 countries on early cancer detection, vaccination, and cancer control. He is also the recipient of the Ernest Wertheim Award in Austria, Princess Lala Salma International Prize Morocco, Paul B. Corbone Award for International Oncology USA, and British Colposcopy Society Founders Medal from the UK. He has more than 280 publications in international peer-reviewed journals, such as the New England Journal of Medicine, Lancet Oncology. So we would love to hear from you, Dr. Sankaranarayan.
Yeah. Thank you very much, Dr. Bhagyalakshmi, and the organizers for the opportunity and for your kind words. And thank you, sir, for your kind words. I think it's an excellent webinar, and we heard very comprehensive presentations on cytology as well as on thermocoagulation, the thermal ablation for the management of invasive, pre-invasive lesions. I think quite a lot of progress has been made, and people are always talking about the elimination of cervical cancer. And actually what WHO aims is before 2030, all the countries would have implemented HPV vaccination to cover at least 90% of the girls below the age of 15 years. And at least 70% of the women would have been screened at the ages 35 and 45, with 90% of the cervical precancers treated. And then about 90% of the invasive cervical cancers, the diagnosed invasive cervical cancers, are treated. So these input measures are supposed to be in place in all the countries, all the signatories of the World Health Organization by 2030, so that eventually you will see cervical cancer brought down to less than 4 per 100,000 over a period of time. And some of the countries will achieve the elimination much more faster, like for example, Australia is expected to achieve elimination by 2028. But many of the low and middle income countries will achieve, if they succeed in putting these interventions in place by 2030, they may achieve this in the next 30, 40 years. So it all depends upon how comprehensively the interventions are put in place. And in that context, the management of cervical precancerous lesions, thermal coagulation has, the thermal ablation has a major role. And it makes treatment much more feasible and possible and acceptable and safe. And this is a highly portable instrument. Whichever thermal ablator that you use, you know, it is a highly feasible method of treating cervical precancerous lesions. And there is a misconception that thermal coagulation cannot be used for treating CAN3 lesions. It is not true. You can treat CAN2 and 3 lesions, and the criteria for the selection of cases is essentially depends upon the type of the transformation zone and the clinical extent of the disease, as very clearly explained by Dr. Smita. And the collaboration that IARC had with the LIGA is an excellent example of a public-private partnership. And actually, I had to undergo almost 2 to 3 years of negotiations with the WHO legal department before this collaboration can be established, because I had we had a grant from the National Cancer Institute in the United States, which helped us to develop, to contribute to the development of the handheld thermocoagulator in close collaboration with LIGA. It is very nice to hear from Wallace today. And Dr. Walter, as Wallace said, Dr. Walter Pranjival, whom I consider as the father of loop electrosurgical excision procedure, had a major role to play in this, because he was the senior visiting scientist at IARC when I was heading the early detection prevention section and the screening group. And we had this grant from the National Cancer Institute, and we established this collaboration with Liger Surgical. And the prototypes were evaluated in several places, and finally we have a product. So at the moment, both VISAP as well as the LIGA have portable units which are available in the market. And I think thermal ablation has a very important role to play, and it will live up to its expectations. And we have to also take into consideration a changed scenario, because whether we like it or not, whether there are substantial criticisms or not, HPV vaccination is going to be a reality. I think the Indian vaccine should be available by the end of next year, hopefully, and which will totally transform the vaccination scenario across the developing world. So eventually we will come across a situation where there are very few 16, 18 HPV infections, and mostly they will be the non-HPV 16 and 18, which will cause transient infections and transient low-grade lesions. And in such situations, the treatment has to be highly selective. You will come across smaller lesions and things like that. So thermal coagulation has an important role to play in future in the post-vaccination scenario. And Dr. Smita, she was one of our very important collaborators who did a pioneering study in evaluating thermal coagulation, both in non-HIV and HIV-infected women. And we have all this information on the HIV-infected women, both from her studies and Dr. Sahasrabudhe's studies in India, as well as in sub-Saharan Africa. So we have an enormous wealth of evidence pointing towards the efficacy, safety, feasibility, and acceptance of thermal ablation, and it is time to implement. And this is a highly affordable instrumentation, medical instrumentation, and highly affordable forms of treatment. I think I would encourage every gynecologist who practices cervical cancer screening to have a thermal ablator, whichever brand they choose, depending upon the price band, and whoever provides you with the most affordable pricing. You can have a unit, and you will do a yeoman service in reaching treatment to women who have been detected with cervical lesions, which is one of the major missing links which has made screening unattractive and ineffective in many places, because the link between screening and treatment was a very, very challenging task. And I'm very glad to say that Tamil Nadu Health System Project, which runs a massive screening program in Tamil Nadu, is now switching over from cryotherapy to thermal ablation. And in Africa, many of the countries, because I was very closely associated with Zambia, encouraging them to switch over from cryotherapy to thermal ablation, and they have now totally replaced the ablative treatment towards thermal ablation, which is possible, which has been made possible because of the commitment of the government, as well as the experts within the country who supported, as Wallace pointed out, Dr. Manohamundu and Dr. Grasbeck Barham were instrumental in such initiatives. So finally, I would like to thank Dr. Bhagyalakshmi for the opportunity to address, because the way that we went into thermal ablation is, I remember very well when in 2000, when we were initiating all these studies in the developing world, Dr. Pat Sauta called me and told, why don't you use thermal ablation? But I regret not listening to him at that time. And then we started using thermal ablation only about 10 years back, when we were not able to afford to maintain cryotherapy service in many of the African countries, because the gas was very expensive, and the availability, the supply chain for the gas is something which is untenable in many places. Anyway, we have a good solution for the management of cervical precancerous lesions, which we should adapt and go ahead with. Thank you very much for your kind attention.